All right. So good afternoon, everyone. My name's Grant Russell. I'm Professor of Primary Care Research at Monash University, and I'm Chair of the Australasian Association of Academic Primary Care's Policy and Advocacy Committee. I want to begin today's webinar by acknowledging the Wurundjeri people of the Kulin Nation, who are the traditional custodians on the land on which this teleconference is hosted in Melbourne. I also acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past and present, for they hold the memories, traditions, culture and hopes of Aboriginal and Torres Strait Islander people of Australia. In recognition that AAAPC is a binational college, I'd like to take this opportunity to acknowledge Maori as Tangata Waihuna and Treaty of Waitangi partners in Aotearoa, New Zealand. We've been really delighted by the interest in today's webinar. For those unfamiliar on the call with AAAPC, we're an organisation that represents the primary care academic community in Australia and New Zealand. We advocate for high quality primary care services in both Australia and New Zealand, run a range of capacity building initiatives and have a major focus on fostering the careers of those new to the discipline. Today's webinar is one of a series, and it brings together 3 international leaders with complementary experience in primary care policy and research translation. We have 2 co-facilitators. Professor Sarah Dennis, Professor of Allied Health at the University of Sydney, and Dr. Samantha Chakraporty, Senior Research Fellow at Cochrane Australia and the Australian Living Evidence Collaboration at Monash University. I'd now like to invite Samantha to introduce our panel and to commence proceedings.
Wonderful. Thank you, Grant. And it's great to be here today. Sarah and I are very excited to be facilitating this webinar today, in which we will discuss with our fantastic panel how to effectively engage with policymakers to advocate for change. Our plan in the webinar is to hear from our members, from our panel members, about examples of what has worked and why, both from the perspective of an insider and an outsider in policymaking. We would like to invite members of the audience to put your questions in the chat, and we will aim to bring these to our panel throughout the webinar. So let me invite each of our panel members to briefly introduce themselves before we kick off with some questions. Peter, shall I invite you to introduce yourself first?
Well, thank you, Samantha. Tēnā koutou katoa. It's a real pleasure to be here. Thank you for the invitation. My name is Peter Crampton. I am a Professor of Public Health in Kohatu at the Centre for Haura Māori at the University of Otago, based in Dunedin in the southern part of New Zealand. By way of introduction, let me say just a few things to give you some context. I was born in England, lived there till I was 12. My family emigrated. I graduated in medicine in 1985, and my first proper job was as a GP in a very low income area on the outskirts of Wellington, the capital city. And that shaped my view of the world then and has hugely influenced my career ever since. Becoming frustrated by being the ambulance at the bottom of the proverbial cliff, I shifted sideways into public health and did that vocational training program. And my interests ever since have been, to some large extent, orientated around primary healthcare policy. And I've been deeply engaged in that world. My PhD 20-odd years ago was on the subject of ownership structures in primary care and policy related to that. So I work in the discipline of public health. My work has always been very much on the wheels of policy. I've worked very closely with policy agencies, much of that in the area of primary healthcare. Right now, for example, I work as I'm the chair of a working group for the Director General of Health, and our job is to help develop a 10-year strategy for primary and community care for the country. I'm a member of a technical advisory group on capitation funding formulas And I'm going to come back to that later on as an example of policy engagement. And I work very much in the area of Indigenous health, Māori health. So that's a little bit about me, and thank you again for the opportunity to be here. Samantha, back to you.
Thank you. Welcome, Peter. Bronwyn, can I invite you next to introduce yourself?
Thanks, Sam. I'm Bronwyn. I'm the CEO of Allied Health Professions Australia. So I was a podiatrist for about 5 minutes, 25 years ago. I haven't worked clinically for 24 years. I've spent the last 20 years working in policy and advocacy in the primary care setting. So mostly on the outside of government for the majority of that time. My first policy job was in the rural faculty at the College of GPs 22 years ago. But I spent quite some time, I suppose, working for the college, working for the nurses for 8 years, working at the Physiotherapy Association. I worked for the Clinical Evidence Task Force during COVID, but other than that, the majority of my time really has been spent really advocating from the outside in with an association lens. So that's really the lens that I bring today. Thanks, Sam.
Fantastic. Thanks, Bronwyn. And Michael, can I ask you to introduce yourself?
Thank you, Samantha, and hello to everybody. Nice to see lots of familiar names among those who've joined the webinar today. I'm Michael Kidd. Probably the most important thing that I have to say about myself is that I've been a member of AAAPC since 1988 when I joined as a GP, academic GP registrar. I was based at Monash University at the time. Since then, I've worked as a general practitioner, particularly providing care to people with HIV/AIDS, strong focus on mental health and Aboriginal and Torres Strait Islander health. I've had academic roles at the University of Sydney, Flinders University, the University of Toronto in Canada, the Australian National University, and now have a joint position between the University of New South Wales and the Nuffield Department of Primary Care Health Sciences at the University of Oxford. I was the Deputy Chief Medical Officer of Australia during the COVID-19 pandemic, and I've been President of the Royal Australian College of General Practitioners 22 years ago, Bronwyn, and also past President of the World Organization of Family Doctors, and that's probably enough. Thanks, Sam.
Fantastic. Thanks, Michael. What a panel. With that, I will throw to Sarah to kick us off with some questions.
Thank you, Sam, and thank you very much to the panel members for giving excellent context in terms of your background and what you can bring to this webinar today. So I'm going to kick off with our first question, and we're asking you to give us an example, and it can be any size, a big example or a small example of a change that you were successful in getting over the line, and what enabled that and how did that happen. And maybe I'll keep the same order, so maybe I'll start with Peter.
Thank you, Sarah. Well, the example that I'm going to talk to is a slow burn, long-term, behind the scenes to some extent issue that I've been involved with for upwards of 30 years. And I'm talking about the design and implementation of capitation or population-based funding formulas for general practice and related services. I would characterize this policy area as being complex, endlessly interesting, contested, and also in need of regular review and evolution. My involvement in this grew directly out of my work as a GP and my experience and also understanding that the distribution of resource into primary care in New Zealand, and we're talking about the late 1990s and the early 2000s, was highly inequitable. And we needed tools and means to distribute resource more equitably. And around that time, it was a time of tremendous change. The opportunities arose for the introduction of capitation funding formulas. And they were introduced successfully following a change of government in 2000 and a new strategy in 2001. Then the wheels fell off a bit because those early formulas, which I was very much involved with developing, were not very sophisticated. And we knew, and we said repeatedly, all those working in that area, that those formulas would need to be reviewed and updated fairly promptly. But they weren't. And I would characterize the funding policy development over the last 20 plus years as being actually not that different from what I observe in the US, where it's growth, it's ad hoc solutions to partial solutions to problems, which get piled one on top of the other. And that's what we've had for a very long time. Right now, I mentioned a technical advisory group just before. We are involved with a much needed update of that formula because the information capacity of the system now is infinitely greater than what it was 22, 23 years ago. And we are able to design really quite sophisticated capitation or population-based funding formulas for GP and related services, primary care services. The big uncertainty right now is whether those formulas, the new ones, will be implemented. It's very hard to read the current government and what direction it would like to go in, and maybe we'll return to that, Sarah, later on. So what I would say is that lessons that I've drawn from that experience over a very long period of time is that the long-term nature of the issue is important, being involved and engaged, actively so, writing, researching, maintaining interpersonal relationships with decision makers, policy makers, and also technical people who work behind the scenes within the system. Those are very important components. And I would emphasize the personal relationships sustained over time. That matters so much. I have so many off-the-record conversations with colleagues and friends who work within the system. And we share information in both directions. That is an important component of those relationships. My status, I would say, is insider and outsider. More outsider than insider, but there's definitely an insider element to it. Credibility and expertise matters a great deal, in my experience. The reasons that I'm involved with those various activities and working groups now is because I would be perceived as having expertise and credibility in that particular area. If I didn't, if that perception was not there, then I wouldn't be invited to be involved. And that credibility and expertise is maintained through ongoing research and publishing in that particular area. So I'll leave it at that, Sarah. Thank you for the question, and happy to answer queries if they come up.
Excellent. Thank you, Peter. And there's a couple of things that I'm going to come back to when we've heard from Bronwyn and Michael, particularly how you maintain those long-term relationships in a system where there's people churn. So I'll hand over now to Bronwyn, please.
Thanks, Sarah. Peter, I'd echo everything there about relationships. So I guess my lens obviously is from the outside looking in. And so mostly when you're on the outside, you're on the receiving end of a policy rather than in the formation of a policy. So I wanted to just make a comment on culture, and that is that my observation would be that really across, when we look in primary care, across general practice, nursing and allied health, each profession and its associated college or association has its own cultural identity. And that identity really shapes how you advocate and the tone that you bring to the way that you advocate to achieve a policy change, depending on who you're advocating for. So the policy change that I'm selected is pretty stock standard, and I've selected it because I think it's got all the necessary ingredients to get a change over the line. I'm going to talk about the Commonwealth Natural Therapies Review, which will be very familiar to some of you. So the background is, just in a nutshell, in 2017, a review of the Australian government rebate on private health insurance for natural therapies was set up to examine the evidence of clinical efficacy, cost effectiveness, safety and quality of natural therapies. And in this first tranche, amongst others, Pilates was considered to be in scope. So the outcome of that review was that the Commonwealth Government introduced a policy that meant from the 1st of April 2019, 16 natural therapies, including Pilates, would be excluded from a private health insurance rebate. So at the time, I worked at the Physiotherapy Association. The natural therapies review had been a back burner issue for us over late 2016 into 2017, and previous opportunities to intervene had been unsuccessful. So if you fast forward to November 2018, it was really clear to us that the outcome of the review was going to be problematic for private physiotherapists. So the workforce context for this change was that some physios across the country have built a business model based almost exclusively on Pilates, and that was going to be unravelled. So I'm going to jump to the outcome and read you the policy carve-out that was negotiated, and then we can briefly unpack how we got there. So this is the wording that was released by the department in March, so a couple of days before the 1 April 2019. So the department considers that an insurer may lawfully pay benefits if a physiotherapist providing services to a patient within the accredited and accepted scope of clinical practice uses exercises or techniques drawn from Pilates as a part of that patient's treatment, as long as the exercises or techniques are within the accepted scope. However, if a physiotherapist or any other health professional conducts a Pilates session, either advertised or promoted as such, as a session where the only service provided is Pilates, then benefits cannot be lawfully paid. So that carefully crafted paragraph, along with some requirements from the private health insurers that sat behind us, allowed consumers to continue to claim for physiotherapy services where the exercises were drawn from Pilates and was the primary treatment. So very briefly, how did we get that carve out and how did we arrive at that place? There's really 4 parts to the process, and I think that all 4 of these things need to be present to achieve a policy change. So the first is that the problem was really clearly identified. A clearly defined problem for a workforce often generates really high member engagement, and high member engagement equals often really high board engagement. And high board engagement means that you have a remit to reallocate policy resourcing towards the issue. So we've got a problem. We then needed to reshape the problem because it's not palatable to make a problem about a workforce. We needed to reshape it towards the consumer. So to do that, we set about making our problem a problem for the private health insurers. And to Peter's point, we drew down heavily on existing relationships that we had. So we drew down on those relationships with the large private health insurers who we knew well, and we began to talk to them about consumer value out of the ancillary product. This issue fell for us over Christmas, so we went to town and used mainstream media and got lots of mainstream media with a focus on the impact on consumers. If this was to come into place on the 1st of April, they wouldn't be able to draw down on their rebate for Pilates. So once we'd built really strong buy-in from the private health insurers, because we'd left them with not a lot of other places to go, we were then able to sit down and talk about a policy carve-out and what it might actually look like for the physiotherapy workforce. And once we had the bones of an agreement in place, which is more or less along the lines of that wording I read out to you, it was then time to go to the department and work with them about finessing and refining that wording, which was then released 3 days prior to the 1st of April. So that's over to you, Sarah. That's my example.
Excellent. Oh, thank you, Bronwyn. So you, just to clarify, you had the wording or you had some draft wording and then went to the policymakers, or you workshop the wording with the policymakers? You went to them with a solution?
So we went with a problem first, but a problem without a solution is rarely solved. So we flagged that we were not going to be able to live with the policy as it currently stood from the 1st of April. So we then set about, I guess, working with the insurers on an arrangement that they could live with and that met the requirements of our physio workforce, put the draft structure of what the wording would be, and then went and worked with the advisor to the minister at the time. So by the time it arrived at the minister's doorstep we had all the stakeholders in play that needed to be in play, rather than bringing a problem with no stakeholders as part of the mix. So all the hard work was done. So really it's presented as all you have to do is agree. It's all the hard work sits over here on the outside.
Yeah, fantastic. Thank you. Thank you, Bronwyn. Michael, over to you.
Thanks, Sarah. Just as an aside, I'm currently chairing the new review of natural therapies for the Australian government, which builds on a lot of the advocacy work that Bronwyn carried out with other colleagues. I think, Sarah, that for me, the most important part of this is any reforms that I've been involved with, I have not done on my own. It's been a team effort. I've been involved in working with colleagues and often from across a wide spectrum of backgrounds. The example I wanted to give is one that some of you may have heard me speak about before, and it's about my first week working as a public servant, as Deputy Chief Medical Officer. I was summoned back to Australia from Canada by Brendan Murphy, who was the Chief Medical Officer at the time, in February 2020. To assist with the nation's COVID-19 response. I arrived on the Monday and said, what can I do? And Brendan said, the Minister would like a national primary care response to COVID-19. And I said, yep, that's great. What have we got? He said, we haven't got anything. And I said, okay, and when does he need it? He wants it by lunchtime tomorrow. Fortunately, I'd been doing quite a lot of reading about what had happened in previous epidemics and pandemics around the world, and particularly the impacts on primary care and the contributions that primary care had made. Toronto, where I'd come from, was one of the cities in the world which had outbreaks of SARS during the SARS pandemic of 2002, 2003. A number of healthcare workers died from SARS in Toronto, as happened also in Hong Kong and elsewhere. And there've been a number of inquiries, and I'd read through those inquiries. One of the healthcare workers who died was a family doctor, a general practitioner. And there were inquiries about how to better protect the primary care workforce during an epidemic or pandemic. So I sat down with amazing colleagues in the Department of Health, and we worked through a strategy, pulled an all-nighter, as we did often during the early days of the pandemic, and presented a plan to the Minister the next day. The plan was built around 5 key principles. Number one, that COVID-19 was affecting some of the most vulnerable people in our population, and they needed to be protected, especially the elderly, people with chronic disease, people who are immune suppressed. Number two, that we needed to separate patients with respiratory symptoms from those receiving regular care in primary care. Number three, we needed to make sure that people continued to receive regular care from their primary care services, knowing from past experience in other epidemics and pandemics that often more people die from neglecting to get health care for regular issues than die from the infectious agent. Number four, we needed to provide the same level of protection to people working in primary care, working in community health services, as we were providing to healthcare workers in hospitals, in emergency departments and ICUs. And number five, again, from past experience, we knew that there would be a long tail of mental ill health and distress after the acute phase of the pandemic had passed, and we needed to look at resources. So we had those 5 principles. We developed responses to each of them, which included moving much of Australian healthcare delivery to telehealth, which is something that had been very resisted in the past by the Commonwealth, looking at the provision of PPE and other supports to people working in primary care, the establishment of standalone general practice services to do respiratory assessments. We call these general practice respiratory clinics. Funding to make sure that while we change the model of care to telehealth, that the nation's general practices would not become bankrupt, that there'd be funding to allow them to continue to employ their staff, particularly their practice nurses, during periods of lockdown, which we're anticipating, and a number of additional funding for resources for mental health. So we presented that. Brendan took it to the Minister, Greg Hunt, came back and said, yeah, the Minister loves the plan. Now he needs it costed. We said, that's fine. When does he need that by? lunchtime tomorrow. Pulled another all-nighter, reached out to people right across the department and said, how much do you think these different endeavours will cost? Got no response back from anybody because everybody was busy dealing with other aspects of the pandemic response. So I got the whiteboard out and with colleagues in the department, we worked out what we thought this would cost, recognising that asking general practices to change their model of care overnight was going to come at a cost. It was going to be expensive. And that needed to be accounted for. We presented back to Brendan, costing of $1.2 billion for the first 6 months. So from February through to September, which is how long we thought the pandemic might last. We were hoping it would do as previous pandemics had and burn itself out in 6 months, how wrong we were. Brendan took that to the minister, came back. The minister's very unhappy, $1.2 billion. He thinks that you have really seriously underestimated how much this is going to cost. He's going to ask Cabinet for $2.4 billion. So that's what he did. The next day, Cabinet approved. It's the most money I've ever spent in a week, $2.4 billion. And on the Friday of that week, we had the final face-to-face meeting with stakeholders, where primary care stakeholders from across the country came to Canberra. We presented the plan. We presented what was supported and approved. We got a lot of feedback on ways to make this actually happen. And then the following Monday, we started to roll it out.
Oh my goodness, I'm exhausted just listening to that, Michael. But I guess what I'm hearing as well in parallel to Bronwyn's story is it's working up the solution and taking the solution to the minister. Yes, excellent. Oh, wow. Now, my question, and there is a question in the chat that relates to this too, is obviously my experience of the Commonwealth is that there's rapid turnover of staff. And so all of you have talked about those relationships. So how do you, just briefly, how do you maintain those relationships when people are changing? And the question in the chat was also, does that extend to the media as well? So whoever would like to jump in and answer that.
Okay, well, Bronwyn, were you going to speak?
No, you go, Peter, and then I'll comment on the media.
Yes, and I was going to comment on the media too. So I go to a lot of trouble to maintain long-term relationships with media colleagues. I have coffee with them. I do a lot of talking off the record, which comes with the risk of course, disclosure. But the relationship is worth nothing if you don't trust each other. So just to say, I put a lot of emphasis on that. In terms of maintaining relationships where there's churn, difficult. It requires effort and persistence. And right now, there's been so much churn in our central policy agencies that it's sometimes hard to know who's doing what, and in fact, impossible to know who's doing what. So they're my brief comments on that. And over to you, Bronwyn.
Thank you.
Thanks, Peter. I get my comment on the department actually would be that most people don't leave, they just pop up somewhere else. So you just need to keep an eye on where they pop up. So it actually is very worthwhile investing time and energy, because relationships are everything. Without those, you don't get meetings, you don't get to talk to the people that you really need to talk to. You get stuck talking to people who can't affect the change. And so in order to make your way to where you need to be and talking to the right people inside the department, you do need to value and hold on to those relationships, and they will bear fruit even if they move sideways and pop up in a different branch at a later date. My comment on the media would be it's almost the same thing, is even though they might move across different media outlets, if you don't build up those relationships and you're ringing out of the blue with a particular story, and the Pilates is a good example of that, you do need people who know you, that you can lean on, particularly over Christmas when you're needing particular articles to come out. And so foundationally, relationships across other associations, other colleges, departmental advisors, media, they're the essence of how you get the job done.
Excellent. Thank you.
Can I add in, Sarah?
Yeah, of course you can.
Yep. So a couple of things, totally agree with all that's been said. Building relationships takes time, and it happens over many years. Relationships need to be nurtured, just like our personal relationships. So it's no point, just coming to someone when there's a crisis that needs to be addressed. You've got to build that relationship over time. I think for individual practitioners, though, that's too much of an ask. And so we need to be using our colleges and our professional societies and associations who often have staff or a team who are involved in policy and advocacy work, and who can act as a conduit and facilitate you getting in front of the minister, in front of the shadow minister, in front of relevant policymakers at the right time. I think also each of us can, though, get involved in working particularly with governments. And one of the ways to do that is to put your hand up when a vacancy comes on a committee or a board. Often our colleges and societies are asked, can you send a representative to sit on this group or that group, or to be involved in this consultation? That'll go out to the membership. Putting your hand up and saying, that's something I'd really like to do. I'd really like to do it with some mentorship from someone who's got some experience doing this, so I can do it and be effective in sharing what I do. This is what I did. I was invited as a registrar by the RACGP to join a government committee when we were doing the first primary care reforms back in 1992, and joined a committee which was looking at the computerisation of Australian general practice, which was in a very early stage. I attended 2 meetings, and then the chair got sick and left, and I got invited to become the chair of that committee, and my career working as an advisor to governments took off from there. So, put yourself out there. If someone rings you up and says, we've got a position on this committee and someone's recommended that you be a good person to do it, say yes, give it a try.
Excellent. Thank you very much, Michael. Right, I'm going to hand back to Sam.
Right. This actually takes me really well to my next question. Michael, you briefly mentioned the culture of the organization and kind of working within. I think, Bronwyn, you also did. So just reflecting on AAAPC, we've got a long history in trying to advocate for primary care. But there have not infrequently been some concerns about the visibility of primary care as a discipline within the policy space. Is this an issue, in your opinion? And what can the AAAPC do about it as an organization? But also, what can individual researchers do about it? So, what does good lobbying look like? I'll throw first to Michael.
Well, thanks, Sam. So firstly, I'd like to say thank you and acknowledge those members who have been involved in effective advocacy and policy making. We've got Grant up on the screen here, who's done some wonderful work. And in fact, some of Grant's thinking and research has helped to inform my own policy work in really positive ways. So thank you. And I'm looking at the list, I can see lots of other people who've been doing lots of work over time. For the Australian Government Department of Health and Aged Care, primary care is central to so much of what they do, and it's so important to so many of the reforms which are currently underway to improve the quality of healthcare, the access to healthcare for people in our country. So now more than ever, I think it's important that we have a strong, consolidated voice from the AAAPC. For an organisation like the AAAPC, I think it's important having a number of clear messages, a number of clear areas that we want to target as an organisation. And our focus is on research. Our focus is on building capacity for primary care research. Our focus is on trying to get more funding for primary care research, recognising that a very small amount of NHMRC and Medical Research Future Fund investment goes into primary care, yet that's where most of the healthcare delivery takes place in Australia. So I think we have some very strong and powerful messages, and we need to be building on that. We have had some successes in recent years. We had last year over $100 million of research funding for primary care released through the Medical Research Future Fund. And I know a number of people online, I know, have put forward grant submissions to seek access to some of that funding to do some incredibly important work for the nation. So keep doing the good things you're doing. Be really clear in what it is, though, that you want to see achieved, and then stick to your messages.
Great. And I've got a couple of questions in the chat that actually follow up really nicely from this. So I'll just read about the kind of similar. So one person has asked, how can we nurture a culture of healthy engagement with policymakers? So not pulling all-nighters to generate something within 24 hours. And then David Gonzalez-Chica has asked a related question about the time constraints and competing demands. So given the time constraints and competing demands that many primary health clinicians and academics face, what are some practical strategies for engaging with policymakers in a meaningful way without sacrificing other essential responsibilities such as clinical work, grants, supervision, etc.? Who would like to take that?
And certainly talk about avoiding the all-nighters, because that'd be a great thing to do. I mean, the all-nighters, unfortunately, were part of the necessary response during a national and global emergency, like the beginning of COVID-19, if we were to save lives in our country. But that is not the normal way that I'd like to do work. I think for us as individuals, firstly, pick your passions. Work out what it is that you are passionate about and that you want to see change. You can't be passionate about everything, so work out what you want to change, and try and get involved with government decision making on a committee, preparing a submission to an inquiry, reaching out and saying, can I speak to an inquiry at a state level, territory level, national level, whatever level it is that you want to try and impact. Yes, David is quite correct. You know, we've all got competing demands on our time, so you need to be strategic in what you do. And for me, a lot of this is working with your organisations, like AAAPC, like the colleges and professional societies and associations. Not trying to do it yourself as a solo voice. You may be effective and may be able to get some things happening. You know, we have some colleagues who write opinion pieces for Australian Doctor or Medical Republic, which are read by the policymakers, or they'll write things to go on the op-ed pages of the mainstream media, or they'll use social media to try and get messages through. Most of us don't have those level of skills and the time to nurture that. So you know, for many of us, it's working in partnership with other colleges through our organisations.
Yeah, fantastic. Peter, I wonder if you wanted to add a bit, given your experience kind of working with policymakers, and also, you know, what do you teach your students to do in this scenario?
Yeah, well, look, I agree with everything Michael said. He's made some extremely important points there. I think as a general observation, I've always considered working with policymakers as to be integral to my work. So I structure it in. It gets allocated time properly. It's something that I do systematically. It's something I plan to do. And it's something that I am persistent at. So it happens over the long term, not the short term, for me personally. And I think it's a hard thing to do, to parachute in to a particular issue, pick it up and be effective. And I know that's what we need to do on occasions. Sometimes circumstances force that on us. But by and large, for me personally, working on the wheels of policy is something that I construct deliberately into my working life. Just in slightly more general points that I'd like to make on this, and I think this is very context specific. For me personally, I'd like to position my advocacy work or policy advocacy work in a values base which can be clearly articulated. For me personally, that matters. Now, it wouldn't work necessarily for all contexts, but it does for the context in which I'm engaged with policy and policy development or policy advocacy. So clear articulation of the values that motivate me, and that's generally around equity of health outcomes, equity of resource allocation, etc., etc. And also, I tend to adopt a systems perspective wherever it's relevant to do so. And I explicitly do that. And I think for many issues, it's more powerful to take a systems perspective than it is to argue from a very narrow viewpoint, even though that narrow viewpoint may be the point that you want to arrive at some point during a policy debate or discussion. I think it's important for policymakers and those working within the policy machinery to recognise a broader perspective. Yeah, thank you, Sam. I'll leave it at that.
Right. Sarah?
Oh, back over to me. Okay, perfect. So my next question is really targeted initially to Bronwyn, but then obviously to Michael and Peter to add. As we've explained, AAAPC is a multidisciplinary organisation, and we're curious to hear about your experience given the number of professional organisations that sit under the umbrella of Allied Health Professions Australia. So how do you lobby for policy when you represent an organisation such as Allied Health Professions Australia with such diverse membership and often competing agendas?
I think it's the question I get asked most commonly. Actually, my response echoes a little bit about what you're saying, Peter, about not being too narrow. So I guess at surface level, the first thing I'd say is that we do have some pretty hard boundaries. And by boundaries, I mean we don't engage in discipline-specific advocacy. I'm really clear that we don't engage in profession-led advocacy that devalues another profession along the way to be successful. And we don't engage in issues of regulation. So once you move those three things to the side and you think about this at a systems level, it's actually not as complex as what it first appears. So it's definitely true that some of the allied health professions have competing agendas, and mental health would be a great example of that. But if you unpack it a bit and think about it at that systems level, the sector actually want the same outcomes. So there's a shared drive to improve consumer access across all different settings, to have a sustained allied health workforce that's underpinned by a national strategy, to work within a digitally interoperable environment where allied health clinical data is in fact integrated. And so if you think about it at that level, we actually do want the same thing. And so when I'm approaching advocacy and policy, that's the level that we operate. It's operationalised through aged care, NDIS, mental health, but that's the high level. You need to unpack it a little bit. I will, though, just briefly share with you that there's really a hierarchy that's a 6-layer hierarchy that we work through. It's quite structured and it's quite straightforward, though, that we think about before we pick up a new policy and advocacy agenda. And I guess the first question is that we ask ourselves is, what's the policy problem and what's the change that we're trying to introduce? So if the problem can't yet be clearly articulated and you don't actually have a proposed solution, it's not ready. It does require more thinking. And often it stops there and we need to go back to the drawing board, or our professions and associations need to go back to the drawing board. We then think about how many different professions are impacted by the policy and how significant is that policy on the workforce. We then think about, can we readily arrive at a shared policy position? And so it might stop there, and because we can't get to a shared policy position, which we internally spend a lot of time thinking about, and you do need to have a handle on what all 28, broadly, what they think and feel across the various different schemes and what their positions might be. We then think about what's the likely impact on consumers. We think about the question I ask us is AAPA's engagement likely to change the outcome? So do our professions actually need us to engage, or have they got it sorted on their own? And then the final question, which drives what you do about it, is there a listening for this right now? So there might be a problem and a proposed solution and everyone's on board, but there is no political will and listening for that right now. So let's not pick that up. If we've got 10 different problems on our plate, and there's a problem with the MBS, often we will have associations that want to hammer getting a new MBS item, and we're like, you would never pick that up when an MBS review has just been finished, for example. So you need to shelve your policy problem and your policy solution for a decade, and then you can bring it off the shelf in 10 years' time when it comes back, because everything comes back full circle. So the final point is about timing. Timing is everything. And if you've only got we've all got a finite amount of resources and FTE to put towards this, don't pick the things that you're not going to win at right now, because there isn't a political listening for it. So that would be my final point, Sarah. There's probably lots more that underneath that, but at its surface level, that's what it looks like for me.
Excellent. No, that's really useful actually to think about that in the context of AAAPC. Michael or Peter?
Well, if you don't mind, Michael, I'll just add a very quick comment just on that, Bronwyn. Some of the listeners may have heard of the Lindblom model of policy formation, the garbage can model. So it's the polar opposite of a rational policy cycle. It posits that in this garbage can, there are problems floating around, there are solutions floating around, and there are policy actors floating around. And policy is made or emerges when those three elements come together in some combination: an actor who's willing to pick up the issue and advance it, a problem, and a solution. And when I think back on the last 30 years of observing policymaking, it does seem to me there's some salience in that approach. Thank you, Sarah.
Thank you. Michael?
Thanks, Sarah. Just very briefly, I think it's really important to when we can come together as different groups across the primary care spectrum. And so Bronwyn, of course, representing that great diversity of allied health professionals we have across the country. AAAPC is the diversity of people working in primary care, and particularly the primary care clinician researchers. So bring this all together with a single voice, and being able to go and see a minister or a shadow minister or a head of a policy area in government, be that state, territory or national, and saying, I come and I represent the voices of X hundreds of thousands of healthcare professionals, delivering X number of hundreds of millions of consultations to the people of Australia each year. And here's the issue that we feel really needs to be addressed. Can be very powerful. During the pandemic, in my first few weeks, once people found out I had the role that I had a flood of emails and telephone calls from colleagues from many different peak organisations saying, we need to talk to you about what's happening, and we're very concerned, and here's what we need to do. And my solution to that was to set up a primary healthcare advisory committee for the Department of Health. We had 50 peaks, including Bronwyn's, on the advisory group. We met every week, sometimes 2 times a week, sometimes 3 times a week, where people were able to hear from officers in the department about the initiatives which we were rolling out, but most importantly, we're able to provide feedback from their members about what was actually happening in the community in different settings right across the country, providing care to different populations who are being affected by the pandemic. For me, I've never chaired such a highly functioning group as that group. You think getting 50 primary care peaks in the room, you'd have everybody going off in totally different directions. But because we were so focused on protecting the health and well-being of the people of our country, everybody was aligned, everyone was listening respectfully, everyone, I hope, felt that they were being heard. and we were able to move to developing policy, which I think better matched the needs of the community through having that sort of structure in place.
I think we learnt a lot about processes like that during the COVID response. And Dimity, there was a question in the chat from Dimity, but I think that we've probably covered off on most of that in the discussion. So I'm going to hand back to Sam for the final question.
Okay, so in sort of your final thoughts, we'd love to know, what do you, each of you, see as the opportunities for the future in primary care in Australia and New Zealand? And what is one thing that academics should try to do to move this agenda forward? Who would like to go first? Peter?
Very well, thank you. Well, look, I'd have to say to all my friends and colleagues in Australia, the picture for primary healthcare and the health system in general in New Zealand at the moment is, in my view, and this is a widely held view, bleak, very bleak. This is the most shambolic period of time in the health system that I have experienced in my professional life. And primary healthcare is in a state of stress and distress, as is all the entirety of the health system. And in primary care in particular, we're working in a policy, at least I would say a strategy vacuum. We don't know where we're going. It's somewhat ironic because the Minister of Health and this current government has been in place for just about a year. And our Minister of Health is, he's Māori, he's Indigenous, he is a GP, and he is highly accomplished. So it does seem to me somewhat ironic that we're in the state that we're in. I'm inclined to take my own advice and to be patient, be persistent, to focus on relationships with friends and colleagues within the policy agencies, to work behind the scenes as effectively as I possibly can, to maintain credibility and to maintain a very strong willingness to engage and to be part of discussions and part of solutions. You know, the answer to your question is so particular at this point in time for us in New Zealand, and there will be some New Zealand colleagues in the amongst those attending this webinar, and I think they'll relate strongly to what I'm referring to. So thank you.
Thank you, Peter. I don't envy you the situation. Bronwyn, can I throw to you next? We've got 5 minutes left.
Thanks, Sam. I'll be very brief. I guess the opportunity that I see is that I'm taking a silver lining approach. We've got significant reform, obviously, across primary, aged and disability, and that is where there are thousands and thousands of allied health providers working. I detect a distinct shift in language in a positive way, where we are talking the talk about multidisciplinary team care, but I don't yet detect that that is followed by genuine reform that includes allied health. So my I guess future thinking is that when we talk and think about primary care, we think about it at its fullest definition. And whilst general practitioners obviously and absolutely have their role, there are nursing and allied health working in that primary care environment. So my real request is that we think comprehensively about the environment and that we forge much closer relationships between research and associations and colleges, that we bring those two together, because I know it's not the exception, but there are opportunities, I think, in there where if we don't do research for the umpteenth time on knees, and we think more broadly about research that is needed in that policy primary care context, I think we can do some really, really good work together to try and fill the gaps.
Fantastic. Thanks, Bronwyn. Michael.
Thank you. Peter, I'm really sorry about what's happening in New Zealand, because I think things are, as Bronwyn has said, a little better here in Australia, because at least we have a very strong government commitment to aspects of primary care reform, and it's bipartisan. We had a 10-year primary care strategic plan under the previous government. Then we had the Strengthening Medicare Task Force, which was really very much about strengthening primary care, and the initiatives which have rolled out with voluntary patient enrolment, looking at how to better fund and support multidisciplinary team-based primary care, and then looking at how to make sustainable innovations, particularly with digital technology in primary care as well. Now, that's not the full spectrum of things which need to happen, but at least it's some areas where things are occurring. I think it's really important for AAAPC, as we see these government reports start to come out, looking at the scope of practice and funding of primary care and so forth, the AAAPC puts forward responses and sends those to the Minister of Health and Aged Care, saying this is our approach, sticking to our principles about the need for very strong research into all these initiatives which are going forward, and also, of course, the education of our future and current healthcare workforce, to make sure that people are being supported as these reforms start to roll out. Because, as I mentioned earlier, changing the model of care comes at a cost. And we may have great reforms, but they may not be picked up across the primary care sector if people can't see how they're achievable and how they're going to be able to afford to do so. So just wish the organisation every strength in getting your messages across. And I think in Australia, there's a real opportunity at the moment.
Oh, wow, that's fantastic. I have thoroughly enjoyed listening to you all speak and learning from you. It's been an excellent webinar, and I think all of us online today have learned so much about how we can do this better, both individually and as part of AAAPC. So thank you very much for your time this afternoon. And also thank you to the members of the Policy and Advocacy Committee of AAAPC who put this webinar together. And I just want to finish off by saying to those people online who aren't members of AAAPC, you might want to visit our website and find out more about what we do, and we'd be delighted to welcome you as a new member. And we have webinars throughout the year that you would be able to attend. And we're keen also to hear from AAAPC members about suggestions for future webinars that we can run. The recording of this webinar will be made available on the AAAPC website for members to view later. So thank you very much. And thank you so much for your time and your expertise this afternoon. It's been really good.